So, thank you for coming this morning. I'm Masao Iwagami. And I'm presenting about case study of a medication harm assessment, introducing these two papers published as part of my PhD, supervised by Ian. So let me remind you of the schedule of this short course, in which my presentation is located in the middle. And I hope my presentation will be complementary to Ian's talk on Wednesday and in the afternoon, Friday afternoon. Okay, so let me briefly introduce myself. So I graduated from medical degree 10 years ago and doing junior residency and senior residency in Tokishukai Shonan Kamakura General Hospital, the same as Seki Sensei in the pharmacoepi department in Kyoto. And then I decided to study public health in 2012 in the University of Tokyo, and then decided to study abroad. And they first entered MSc Master course in epidemiology in London School of Hygiene, which is now coordinated by Ian. And then decided to go to PhD named Epidemiology and Population Health, and belonging to Electronic Health Records Research Group. And this is me, and this is Ian. And I spent 4 years to finish my PhD. And I came back to Japan last year, and now I'm an assistant professor of Tsukuba in the Department of Health Services Research, and also assisting distance learning courses of pharmacoepidemiology and non-communicable disease epidemiology in London School of Hygiene from this year. So if you have any questions, give me questions or comments during my presentation or in the end, either in Japanese or in English. So my presentation is about to estimate and interpret prevalence of a drug use, incidence, indication in a particular group of patients. And also I'm estimating relative risk of a drug and absolute risk increase or excess risk of a drug for one adverse drug event, using my example of UK primary care data and chronic kidney disease or CKD population and antidepressants and gastrointestinal bleeding. So this is just my example, but I hope that you will apply my methods to your own research using another example, such as Japanese JAMDAC database, diabetes population, antibiotics and heart disease, and so on. So as shown here, I had a lot of difficulties or obstacles I faced during my PhD. And in every step, I had to make a decision to overcome this difficulty. So I will show you honestly my thinking process and how I overcame this individual difficulty. And I believe that I think that it may not be 100% correct or accurate decision, but I hope that my thinking process will help your future decision making in your own research. Okay, first, questions to research questions, by which I mean the start of my research was when I was doing senior residency. I was consulted by a junior residency where the antidepressants can be prescribed for patients with chronic kidney disease, pre-dialysis chronic kidney disease, who may be depressed or just sick. So at that time, I didn't have any answer to this question. But suddenly this came to my mind at the beginning of my PhD, and then decided to tackle with this research question. But you know, this is just question, so not research question yet. So according to these great books written by Fukuhara sensei in Kyoto, I rephrased this question to a kind of research question. What is the risk-benefit balance of antidepressants? And then I split this into two. What is the benefit and what is the risk? Because as Ian suggested on Wednesday, we don't have to examine benefit and risk in a single big study, but this could be separate. So benefit may be more suitable to be assessed by RCT or clinical trial, while risk could be assessed by electronic health records or real-world data, especially among patients with kidney disease who are often excluded from clinical trials. Then, by focusing on the risk side of antidepressants, this is PECO, by which I mean among patients with CKD, comparing antidepressants and no antidepressants on the adverse drug events such as GI bleeding and fracture. So this is the research question in my second paper. And before this, I was interested in the basic statistics. What is the prevalence, incidence, and indication of antidepressants? It's kind of drug utilization study as my first paper. Okay, so for the coming 4 slides, let me briefly introduce what is UK primary care database. So in the UK, there is primary care gatekeeper system or GP system, in which almost all people in the UK, living in the UK are required to be registered to GPs to receive universal health care for free, and as I did during my PhD, staying in London. And by this system, the same GP records a patient's information in primary care, secondary care, referral or specialist consultation, hospitalization, and death. So in theory, a patient can be followed up continuously for his or her life. And there are 7,000 general practices in the UK, and one general practice holds one or more GPs. And this is just an example, Regent's Park General Practice, which I belonged to during my stay in London. And this is another example, Acton General Practice. There is kind of Japanese town in London, and this is Acton. Okay, so Clinical Practice Research Data Link, or CPRD, is one of the several databases in the UK. And CPRD includes data from 700 general practices using the same software provider system, and representing 7% of the UK population in terms of age and sex. This is the example of women. But age distribution is very similar between CPRD and UK census, or 人口動態統計 in the UK. But it's not representing geography and socioeconomic status, because CPRD started from London. And density, or the number of participating in CPRD, is higher in London and northern area in the UK. And another strength of the database is linkage to inpatient database as well as cancer registry and myocardial infarction registry for 60% of the cases in CPRD. And this is a kind of data structure of CPRD, which may be similar to Japanese JAMDAC database. So for example, women born in 1965 registered in August 24th, 2004 in practice number 189 in East London of England. If she visits GP on November 21st, 2012, a doctor or GP diagnosed her as having urinary tract infection and some extent of dehydration, and prescribed antibiotic, trimethoprim in this example, for 5 days. 10 divided by 2. And if GP measured and recorded blood pressure, this is also recorded, but not every time. So like this, the data are stored separately. And if researchers want to do a study, so they split and merge these data sets into a single data set for analysis, like we do in Japanese JAMDAC database. And another strength of CPRD may be it has a range of lifestyle-related factors and vital signs and blood tests. But the data is not for everyone. So even after 2004, the smoking was recorded for 95%, while blood pressure, BMI, alcohol were recorded for lower proportion of patients. And total cholesterol, like blood test, is even lower. So how to deal with missing data may be more important and difficult. Although I don't have time to talk about missing data today. And in terms of diagnosis recording, in 2004, there was a kind of incentive system for GPs to record more accurate diagnosis. Was introduced in 2004, quality outcome framework, so that diagnosis recording of such as diabetes and heart failure improved very much. So that most researchers these days tend to use data after 2004, as I did for my PhD. So I used data from 2004 to 2014. Okay, do you have any questions so far? Okay. So I'm focusing on how to estimate a prevalence of a drug use in a particular patient group. I mean, prevalence of antidepressants in patients with chronic kidney disease. The first difficulty I encountered was how to identify a particular patient group or study population. And of course, it's case by case. I mean, depending on disease, database, and country practice. But there are some strategies to identify particular patient group. And in the case of chronic kidney disease, diagnosis is kind of notorious for its low sensitivity. So if available, I wanted to use these biochemical information such as blood test and urine test. And my decision was blood test. And I didn't decide to use urine test, mainly because, of course, urine test is very attractive to identify proteinuria. But I found that the testing rate of proteinuria was less than 20% in the UK general population by primary care physicians. And another difficulty was there was no way to differentiate proteinuria by infection and proteinuria by kidney disease. So urine test may be conducted at the time of urinary tract infection. So there could be misclassification of proteinuria status. So considering the possibility of misclassification and missing data, I decided not to use urine test for my research. And this is a kind of criteria, established criteria internationally, CKD criteria 2002. And my research study population is equivalent of eGFR, estimated glomerular filtration rate, calculated by serum creatinine results, equivalent of stage 3 to 5. So my research focus was this patient group among CKD. And these days, more sophisticated CKD classification is proposed. And according to this classification, my study population is, this row is based on blood test, and the column is based on urine test. And my research was focusing on this group. And these days, reviewers tend to ask, how about microalbuminuria or urine test? But it's very difficult to adjust or identify urine results in UK primary care data or in many primary care databases in which, unless urine test is very common by primary care physicians. So that's a reality. And this is a common trajectory of kidney function decline over 10 years from 2004 to 2014. And in real world data, blood tests may be conducted at the time of acute illness, infection. So in that case, patient kidney function may be temporarily dropped, named acute kidney injury. So to reduce a possibility of chronic kidney disease and acute kidney injury, I needed 2 kidney measurements to identify CKD population, to exclude patients with AKI, acute kidney injury. So by graphical representation, I included, so patients measure their kidney function at different timing. And At the second time, eGFR less than 60 was observed. I included each patient into CKD cohort and established a kind of CKD cohort in my study. Okay, as such, among 4 million patients registered in CPRD between 2004 and 2014, aged 18 or older, I identified 260,000 patients with CKD stages 3 to 5, accounting for 6.5% of the general population. And I confirmed that this is generally representing the UK CKD population because I compared these patients with nationally representative statistics as a validation study, health survey for England. So you can see this is women, but man was similar. So by age, the prevalence of CKD was very similar between the databases. So by doing this kind of validation study, you could make your research more variable. Okay, so by identifying CKD population, the question was what is the prevalence of antidepressant use in CKD? But the second difficulty I encountered was at which point should I define prevalence? So prevalence is generally defined as number of people with a drug divided by total number of people at risk in the population at a specific time point. But my question was which I should use at a specific calendar time, like July 1st, 2010, or at CKD cohort entry. So I had two options. So if I chose number one, it's like this. So this is the CKD population. And this is the second option. So if I wanted to estimate a prevalence in the general population, probably I chose the first option. But if in a particular patient group like CKD population or diabetes population or cancer patients, patients are identified as having a disease at different timing. So that if you focus on one calendar time period, the number of patients included in the analysis is limited. So in this case, I decided to use number two option. So I looked at the prevalence of antidepressant use at cohort entry for every patient. And I looked back 6 months according to previous studies using UK data to identify prevalence of antidepressant prescription. And as such, I estimated a prevalence of antidepressant use to be 16.3% in CKD patients. And if stratified by cohort entry timing, I found that this was gradually increasing. So in 2013, 20%, meaning that among patients with CKD, 1 in 5 patients are on antidepressants at one timing. So I felt like to say this is high, but the matter is I couldn't discuss by this number high or low because there is no comparison. So let me use a kind of example. So Nishikori. I often cheered for Nishikori in this is London final and Wimbledon, and this is Davis Cup between Japan and the UK. And people often say that Nishikori is smaller than other players like Roger Federer. But my impression I saw him in Wimbledon was he's quite tall and taller than other Japanese. So what I mean is the comparison, totally matter of comparison, whether or not this is high or not. So I needed to make an appropriate comparison group. So what I did was I had 4 options. So one, all the others in CPRD. And the second option was random sample from CPRD. And the third option was age and sex matched patients. And number 4 was propensity score matched patients. So first, I felt like to choose number 1 or number 2. But what I found was the age and sex distribution was quite different between the groups. So if I chose number 2, maybe it's nothing different from comparing older people and younger people about antidepressant use. So I needed to use age and sex matched patients without CKD. And the 4th option may sound attractive because by propensity score matching, you can select patients with similar backgrounds as patients with CKD. But I tried this and found that a number of successful matching was very small because these patients with CKD are most likely to have diabetes, heart failure, and smoking status. And if I try to find propensity score matched patients, there was almost no patients with diabetes, heart failure, and smoking history, but no CKD. So depending on disease, sometimes you should use propensity score matched patients comparison group, but in my case, this was not functional, so I used 3rd option. Okay, so as such, I selected randomly with the same age, sex, in addition to the same general practice and calendar time for more fair comparison, and the same number of patients. And let me note that in this process, 20,000 patients were dropped because these 20,000 patients were 90 years old women. So most of them had CKD. So I didn't find any comparison group from this population. But I mean, for prioritizing fair comparison, I dropped these 20,000 patients and then compared this group and that group. Okay, and this is kind of graphical presentation explaining the same. So this is CKD cohort, and I selected randomly a patient with the same age and sex at the same timing of cohort entry and made a comparison group or no CKD cohort. And then compared prevalence of antidepressant use between the groups. And this was 16.3%, as I said earlier. And a comparison group, this was 11.9%. And stratified by timing of cohort entry. The association was nearly parallel over time, so nearly 1.5 times always. So now I would conclude that more confidently that patients with antidepressants, the prevalence is higher than the general population with the same age and sex in the same GP practice. Okay, so do you have any questions? Ah, いいですよ、日本語で。そうですね、はい。一応97%が、一応イギリスの中でレジスターしていて、で、拒否すれば、いわゆるオプトアウトシステムって言って、拒否すれば、除かれるんですけど、それは、レスダン 5% とか少ないと言われていて。はい、私というよりも学生さんも研究で、高齢者が入ってないのがとても使えない最大のバリアなんですけど、今この年齢が65歳、72歳から出ていいなと思って。ありがとうございます。My question is so, how many patients have the result of blood test of, for example, SSRIs among the patients? The diagnosis of CKD. Okay. So I found that diagnosis was not very useful because patients with CKD diagnosis almost always had creatinine results then in their record. But among patients with serum creatinine results, only a small number of patients had CKD diagnosis. Yeah. So you didn't include the diagnosis of CKD, and you only used the result of blood testing. blood tests because I mean there is no big difference. I mean by using patients with CKD diagnosis, there is no additional benefit.
Okay.
But sometimes I mean depending on the disease, some patients may have only diagnosis but no blood tests. So that I mean depending on, for example, if this is diabetes, you may need to use both diagnosis and hemoglobin A1C, something like that.
We conduct the type of validation study to compare these algorithms. For example, only using the ICD codes or using the test of blood test or combining these algorithms in the future.
Yeah. So I mean, of course, it's totally up to disease and database and country practice. So it's important, at the time of validation study, you make several strategies and which is the best for the database or for the disease. Thank you. Any other questions? Okay. So let me move on to incidence of a drug use. Okay, so incidence was relatively easy. I mean, incidence is calculated by the number of people with an antidepressant initiation divided by total follow-up period among patients at risk for starting the antidepressant. So in that case, non-prevalent users. So let me show the antidepressant prescription period by pink. So this is the period prescribing, receiving antidepressants. And in this example, incidence can be identified as new start of a drug. And so 2 divided by these observational periods. And I excluded the middle patient because he or she was a prevalent user. So his or she is not at risk for initiating new antidepressant. But I had a kind of question. Prevalent users may stop it and restart it. I mean, even prevalent users at the beginning of CKD cohort entry, he or she may stop it and then restart again. So this could be counted as incidence. And even incident users, one patient may have several incidences, like infections. So one patient could have several infections during follow-up period. Of course, it depends on the type of outcome and drugs. But in this case, I wondered very much between I should count 1 per patient or several per patient. But at that time, my supervisors gave me a good suggestion. So they are my supervisors, nephrologists. And Ian was in my advisory committee. And they often give me very useful questions because I often, get bogged down too much. So I wanted to achieve 100%. But she often suggested to me, don't spend too much for that small difference. So this is a very good suggestion every time during my PhD. So I decided not to include, so one patient could have only 1 incidence. And I stopped the observation after that. So I learned that in pharmacoepidemiology, sometimes you need to make a decision to be simpler and don't spend too much time. And as such, incidence of antidepressant use was 57.2 per person, 1,000 person years in CKD patients. And this number is subtracting 242,349 minus prevalent users, so just incident users. And I repeated the analysis in the comparison cohort, and this was 42.4. So obviously, both in terms of prevalence and incidence, patients with CKD were more likely to receive antidepressants. And I also did adjusted analysis by, logistic regression analysis for prevalence. So adjusted odds ratio was 1.4 before adjusting for confounding factors. And after adjusting for confounding factors like diabetes and cancer and other lifestyle-related factors such as BMI and smoking history, it was 1.35. And I also did survival analysis. In this case, I used Poisson regression analysis, but you could use Cox regression as well. And this was 1.35 and 1.25. So this is adjusted analysis. But I believe that these crude values are more informative in this case. But in medical journals, reviewers or editors like adjusted analysis. So it's not bad to show these adjusted analysis results. Okay, so do you have any questions or comments so far? Yes.
How did you specify the confounding factors with diabetes? どんなことですか？
定義の方法っていうか、使ったコードリストとかそういうことですか？それともそのコンテンツというか、その何を選んだかっていうことですか？
元々のファイルに、
はい、
並存表面があるのか、それともレセプトのようなところから、ICD とかで。
そうですね。データベースは傷病名コードっていう、リードコードっていうイギリスのオリジナルなものがあって、それで、だから傷病名コードとほとんど一緒です、日本の。でその中から、例えばダイアビティスだとかキャンサーだとかっていうのを、その項目は自分で決めといて、でそれに値する、いわゆる傷病名コードリストを作る必要があって、でそれは自分で全部作ったわけじゃなくて、チームの中でやっぱり共有してるんですよ。過去にだからダイアビティスの研究やった人はダイアビティスのコードリストを持っていて、あるいはそのスモーキングの研究をした人はスモーキングをどうやって一番よくアイデンティファイするか持ってるんですよ。はい、なんで、シェアしてる人もいれば勝手に個人で持ってる人もいるので、基本的にはそのチームの中の過去の研究やった人を見つけて直接会いに行って、そのコードリストくれとか、そのアルゴリズムのコマンド書いて抽出したりすることもあるので、それやり方をくれって言ってなるべく自分で作らないように。で例えばリウマチ、関節リウマチとかも一応アジャストしたんですけど、関節リウマチの研究をした人はチームの中にいなかったので、それはもう自分でしょうがないから傷病名リストから作って、もう一人の医者にチェックしてもらって、コードを決めたっていう感じになりましたね。はい、よろしいですかね。はい。
例えばチャールソンコモビティインデックスとか、
はい、
ある程度そのクレームセーターでそのバレースされたその定義を使ったり、そういうことはコモビティに関してはあんまり
コモビディティ、チャールソンコモビティインデックスを使うときも基本的にはその各病気を定義して、その合計値でチャールソンコモビディティを定義しているので、チャールソンコモビディティインデックスという形で入っているわけではなくて、ただ、インペイシェントデータに関してはチャールソンコモビディティインデックスが入っているんです。それは医者がつけてるんですけど、でバリデーションスタディがやられてるかっていう問題は、病気によります。でただ一般的には僕はよく言ってるのは、正しいかどうか置いといて、研究のアウトカムと研究のエクスポージャーは常にもう徹底的にこだわって定義する必要がある。ただ後楽因子に関しては、最悪そこまでバリディティが高くなかったとしても、どっちかというと例えばレビューアーの興味というのはアジャストしたかしてないかに興味がいって、その正確性まで 100% 求められないというのが実情だと思っているので、自分の場合は研究のアウトカムとかエクスポージャー、エクスポージャーはドラッグなことが多いので、それは事実なので、プリスクリプションは事実なので、アウトカムの方だけちゃんと徹底的にこだわって、ない場合にはバリデーション研究をやって、それ以外の項目に関してはなくてもいいのかなっていうのが正直なところです。そうですね。プライオリティですね。I should explain in English. Okay. So his question was about, how I could identify or define comorbidities or confounding factors. And my answer was, her question. So I found researchers in my group who have conducted research on each disease. So to identify diabetes population, I found researcher who has conducted research on diabetes previously and asked her or him to give me code list or how to identify, algorithm to identify diabetes population or diabetes comorbidity. And his question was about validity of each comorbidity. And so my answer was to define study outcome and study exposure. You should stick to 100% accuracy or validity. But in the case of confounding adjustment, generally editors or reviewers do not stick to the 100% accuracy or validity of comorbidity. So that in the real world data, to be honest, myself, I didn't pay much attention to comorbidity definition, but just adjust it as available information. Thank you. Okay. So, indication of a drug use in patients with CKD. So, it's a busy table, but generally, when drugs are prescribed, so some drugs like insulin is obviously prescribed for diabetes. It's obvious, but some drugs like antidepressants or antibiotics could be prescribed for several reasons. So in the case of antidepressants, so this Quebec, Canada study suggested that antidepressants were prescribed only for 55% for depression, followed by anxiety for 18%, and insomnia or sleeping problems for 10%, and pain and 6%, and many other indications. And in the case of antibiotics, antibiotics may be prescribed for pneumonia or UTI or other infections. So sometimes researchers need to identify why drugs were prescribed, because this could be a kind of confounding factor in the study. So this Quebec, Canada database is very special in that every time doctors prescribe a drug, they need to input indication, every prescription. So in that case, identifying indication is very easy. But in most databases in the world, like CPRD and Japanese JAMDAC database, diagnosis and prescription are separate, so that we don't know which diagnosis is contributing to the prescription. So that the kind of strategy is needed to identify when is indication of a drug recorded in the database. So I found, in the case of antidepressants, I found a previous study comparing 7 European databases when the diagnoses are recorded for individual antidepressant prescription. And in the case of CPRD, if you look at only 3 months before and after the incident day of antidepressants, the proportion of indication recorded was very small, at 30%. But if you look back 1 year or 2 years or 3 years before, it's more likely to be recorded. Because doctor, once they input diagnosis, and they never record it again. So it's, different country by country and database by database. So some databases, every time doctors may input diagnosis. But in the UK, it's not, and I don't know in Japan. So according to this result, I decided to look back all the diagnosis records in the database to identify indication for antidepressants. And this is a result in patients with CKD who initiated antidepressants by type of antidepressants and major indication. So SSRI was prescribed for depression 63% of the cases, followed by anxiety 34%, and some neuropathic pain and off-label indication. Off-label means 適用外処方 in Japanese. While tricyclic antidepressants were prescribed not for depression and anxiety very often, but pain and probably sleeping problems or just sickness or some some symptoms. So this is the result. And importantly, I compare this between patients with and without CKD. And importantly, this was not very different. So this is a kind of against my expectation. So I expected, in my clinical experience, I expected that antidepressants are prescribed for off-label or tekyogai shoho in patients with CKD, but it was not in the case in the UK and in the real-world practice, at least in the UK. So it's kind of boring result. So to conclude the first paper, patients with CKD received antidepressants more frequently than Asian sex-matched people without CKD in terms of both prevalence and incidence, while its reasons were not very different. So this is a result of a drug utilization study in my first paper. Okay. So do you have any questions or comments?
I've got a question.
Yeah.
Why did you think that the CKD population would have different indications for the antidepressants?
I mean, generally, I mean, we don't know. I mean, when patients with CKD say they are not very fine, they may be sick or they may be depressed, but may not be depressed, just sick, or tired, or so. If we use the same questionnaire, I mean, for depression,
Yeah.
patients with CKD may be identified as having depression because they answer to the question, they are tired and they are not motivated. So in that case, doctors may prescribe drugs expecting depression, but I mean, in the real world, I mean, it could be for just sickness. In that case, antidepressants may not be effective. So that's why I expected the difference, but it was not. Well, that could be because of just recording practice. Okay.
My question is, so when did you decide that you separate your drug utilization study and outcome study into two studies? And so in our lab, so sometimes we combine it if the total information is not so very much, and sometimes so we separate it. So according to the situation, so at this so which point which time point so you decided?
That's a good question. So first, to be honest, I was okay to publish it in one big paper, but the professor in the electronic health records, who is Liam Smith, always said that one paper should have one message. So in the middle, I found that my kind of objective was a bit different. I mean, the first paper is looking at the prevalence and comparing it in patients with CKD and without CKD. And the second paper was more focusing on patients, the side effect of drug. And in that case, comparison is not between patients with and without CKD, but comparison is between period with and without antidepressants. So if I put these into one paper, maybe reviewers may be a bit confused, or it's over the volume. So one paper can have only 3,000 words. So, but I know that sometimes it's criticized that one research is split into 2 or 3 to make more impact factors or something like that. But I think it's not a bad idea to first publish drug utilization and then move on to the side effects or relative risk of drug in the case of pharmacoepi.
How did you define the diagnosis of depression or anxiety or some psychiatric algorithm or diagnosis in your paper? Did it validate or not?
To be honest, it's not validated. So just this time, I just looked at, used previous code list already published in previous studies conducted by psychiatrists. And so ideally, anxiety and depression should be validated. And also, I didn't talk, but I use not only diagnosis cause but symptom cause. So in the UK database, I mean, there are kind of symptom cause, like, so not depression diagnosis, but I mean just saying depressed. So this may not be diagnosis, final diagnosis, just patients were depressed and doctors chose depressed symptom cause. But if I excluded that the proportion and the prevalence was going down a lot. And previous psychiatrists using this database decided to use both diagnosis cause and symptom cause. Yeah, so that's I mean, of course, tough decision. But in this case, I didn't have time. I mean, didn't spend too much because this was not my study outcome, but I mean, secondary outcome. So I just used previous studies.
Thank you.
Good question. Okay. So relative risk of a drug use for an adverse drug event in a particular patient group using an example of GI bleeding of SSRI as part of antidepressants. Okay, so this is PECO again. So SSRI, the side effects of SSRI, GI bleeding is well established because SSRI affects the function of platelets in the blood. So patients receiving SSRI are generally more likely to have GI bleeding in the general population, but it's unknown among CKD population. So among patients with CKD, so comparing SSRI and no SSRI on the first instance of GI bleeding hospitalization. So this is the CKD cohort again, and these pink suggest antidepressant prescription. But then I had difficulty again. So I wondered between what is comparison? Comparison between people or comparison between periods. So if I chose people, I will compare these three people who are prescribed antidepressants anytime, even for a short period, and the rest of the people, I mean 2. So if the outcome was cancer incidence, probably I should choose this option because once a patient is exposed to a drug, they may be at risk for cancer later. But in the case of GI bleeding, so generally we can expect that the risk of GI bleeding is increased only at the time of drug prescription. So I should have compared periods. So one patient may have both periods with and without antidepressants. So by which I mean I compared periods with and without SSRIs, so pink versus green. That's my decision. But then Ian came to me and suggested one advice. So generally, Ian is very generous about student decisions, but it seems that this time only, Ian was very strict, I mean, had strong opinion about this point. I should have excluded these prevalent users at the time of cohort entry because it's well known that in pharmacoepidemiology, prevalent users could bias the results. And in this example, he says that discrepancy between RCTs and observational studies on hormonal replacement therapy can be explained by prevalent users who have survived without side effects of the drug. By which I mean, this patient was using or on antidepressants because they didn't have GI bleeding before. So that even if I follow them up later, he is unlikely to have GI bleeding. So this patient could bias the association between SSRI and GI bleeding. So according to his advice, I decided to exclude this patient and conducted incident user study design. And the incidence rate of first year bleeding was 4.7 during green period and 9.4 during pink period. And if I conducted survival analysis by Poisson regression analysis, or you could use Cox regression analysis. This was 2.04. And I also adjusted time-dependent confounding factor like NSAIDs use, or warfarin, or aspirin, or anti-acid drugs to protect stomach. And this was 1.79. So I interpret this as during period with SSRI, the relative risk of GI bleeding was 1.79. And I repeated the analysis in the CKD, non-CKD cohort I established during my first paper. And this was 3.0 and 5.7. And adjusted rate ratio was 1.98 and 1.66. So how to interpret the result? So I expected that if antidepressant or SSRI is really risky in patients with CKD, this should be 3 or 4. But the reality was, it was slightly different, but not very different. So, of course, it's good for patients and doctors, but bad news for me because it's kind of boring. So generally, I mean, medical journals like sensational news. And by obtaining this kind of boring result, my result is unlikely to be accepted by high-impact journals. So I further divided this patient group into 3 according to the level of kidney function. But the result was very similar. So there is no big difference of relative risk according to the level of kidney function. And I conducted a test for interaction. So to test whether this relative risk is different between the kidney patient group, kidney function. But there is no evidence. And I further divided them into low dose and high dose, expecting that doctors may prescribe low dose of SSRI for patients with lower kidney function. That's kind of confounding. So I separated, stratified according to dose. But you can see that it's very difficult to interpret these results because of large confidence intervals, because each group became very small. So in the end, it seemed to me that relative risk was not very different, a kind of boring result. But I was kind of confused. So is this SSRI accepted in CKD? And my supervisor said again, in a sense, yes. But I should look at absolute risks to discuss about the appropriateness of use of drug in a particular population. So this went to my final number 5, absolute risk increase or excess risk of a drug use for an adverse drug event in a particular patient group. Do you have any questions so far?
Another question is, did you have an option to use case only design? You include both drug users and non-users, and you compare the using time and non-using time. If you use only case control design, you compare the you can compare more comparably.
Comparison. Okay. So case only data. That's good question, and that's related to Ian's talk in the afternoon. I was attracted by case only design, but it's true that previous researchers tackled this research question. GI bleeding and antidepressants and GI bleeding by case only design, but so the condition required for case-only design is that, especially self-controlled case series, one of the conditions is that the outcome incidence shouldn't change the subsequent exposure probability. And it's now in 2016 or 17, it's already known that GI bleed, SSRIs risk for GI bleeding. So it's highly possible that once doctors find GI bleeding, they may stop antidepressants or SSRI and never prescribe it again. So it harms the requirement or condition to use case-only design. Yeah, so that's the main reason that I couldn't use self-controlled case series design. So still I had the option to use case crossover design, because case crossover design, the requirement, the condition is not required, as Ian will talk later. But I didn't use this time. Yeah. And also, I needed to estimate incidence rate, absolute incidence rate. And in self-controlled case series or case-only design, the absolute incidence cannot be estimated. Yes. Because you only include patients with outcome. So to estimate relative risk, could be an option, but I didn't use that.
Thank you.
Is right? My explanation good? According to Ian. Okay, so absolute risk increase of a drug. So this was crude incidence rate of first GI bleeding hospitalization. Just I illustrated the incidence rate by kidney function and periods with and without SSRI. And obviously you can see periods with SSRI is higher than periods without SSRI. And this is increasing every kidney function decline. So I wanted to discuss based on this result that, and also this is a difference between periods with and without SSRI. And I wanted to discuss this is increasing so that SSRI is not recommended in patients with lower kidney function. But my supervisor came again, and these differences are unadjusted and influenced by confounding factors. And adjusted analysis are needed. So by which she meant that, for example, this period and that period are quite different because other confounding factors such as aspirin or anti-stomach, anti-acid drugs may be different. Also diabetes status may be different. So these are indeed confounded. But I was confused because when we usually do statistical analysis or adjusted analysis, it's logistic regression analysis or Poisson or Cox regression analysis to estimate relative risk. But what is risk difference adjusted for confounding factors? And after learning for a while, in RCTs, treatment group and control group are well balanced because of randomization. And you just take a difference between the groups, which is crude. But this is treatment effect because there is no confounding between the groups. But in observational studies, if you take the difference between the group, this is unadjusted, but these are confounded. So confounding adjustment is needed to estimate treatment effect. This was very new to me. And I consulted statisticians, and he suggested 4 or 5 options. And the first is the easiest one, probably. Hazard ratio or rate ratio multiplied by absolute risk in control group. But this may be a bit different from true effect bias because of proportional hazard assumption. This is a kind of rough estimate. So the statistician didn't recommend me to use this method. And the second option may be crude risk difference between propensity score matched 2 groups. Because propensity score matched groups are equally balanced. So that if you just take difference, this is a kind of adjusted by propensity score. But in this study, my study, this was not useful because to use propensity score matching, you have to calculate propensity score at one time, single point. But in my study, one patient could have both periods with and without SSRI. So calculating propensity score every time for individual patients was difficult, so not realistic. So this was available to me. And the rest were additive Poisson regression model and marginal structure model. This is quite statistically difficult. But after discussing with the statistician, I decided to use additive Poisson regression model this time because I thought that it's relatively easier than marginal structure model. So the details are in my second paper, appendix. It's too long. But I mean, by this method, this is crude incidence. And what happened was this is adjusted. So can you see the difference? So this is as a result of adjustment. So because, I mean, by adjusted analysis, the model assumes that if the confounding factor is equally distributed between these 8 groups, so it's a kind of simulation that what happens if, for example, the distribution of diabetes or aspirin or smoking status was if equal between 8 groups, what happened? So that 8 groups became closer as a result of adjustment. And now these differences can be ascribed to drug because other factors are completely the same in theory. So these differences are drugs. And then I kind of tested. I mean, this can be test for interaction or effect modification can be done by starter, just by putting sharp mark in the starter model, and this was significant. So now I confidently say that the absolute risk is increased according to the level of kidney function, even after adjusting for confounding factors. Okay. To conclude the second paper, relative risk of SSRIs for GI bleeding was constant at 1.6 to 1.5, 1.8, regardless of kidney function. But excess risk or absolute risk increase was increased as kidney function deteriorated. But my question again, so what? So which should I trust, relative risk or excess risk? Or in the end, can we prescribe antidepressants to patients with CKD or not? And I reviewed previous expert opinions and textbooks. And as far as Rossmann says, if you compare relative risk or excess risk or additive interaction may be more important, named public health interaction, because a larger number of absolute risk increase means a larger number of patients suffering from the GI bleeding due to drug. So excess risk is important for decision making in clinical practice. So he suggests that to focus on excess risk. But what I thought was, if discussing about decision making, my interest was also risk-benefit balance. So coming back to this original question, risk-benefit balance. So if benefit is large, a drug could be used even if risk is high. So you may remember that I split my research question into two, benefit and risk. And I focused on the risk side. And benefit side may be more suitable to be assessed by clinical trial or RCT. And by chance, during my PhD, one big paper, big randomized control trial was published for patients with pre-dialysis CKD, well, I mean, the study, same study population as mine. And there was no significant benefit of antidepressants in this study population, sertraline, discussing that lack of efficacy could be that depression comorbid with chronic kidney disease is a different clinical entity than psychiatric major depressive disorder that is not responsive to medications. So in total, benefit is not increasing, or rather decreasing in patients with CKD. And risk is increasing in patients with lower kidney function. So in terms of both benefit-risk balance, both, it's worse in patients with lower kidney function. So my conclusion was kind of a recent RCT didn't show any benefit. In total, antidepressants may not be recommended in CKD in terms of both risk and benefit balance. Although, I should say, more research is needed always. Okay, so coming back to be more comprehensive. So I come back to research questions, 2 questions. So I conducted first paper, drug utilization study, suggesting that antidepressants are more likely prescribed in patients with CKD. But there was a kind of excess risk increased in patients with CKD. And a RCT suggested that the benefit was not there. So in terms of risk-benefit balance, probably we should say antidepressants shouldn't be prescribed generally for patients with CKD. So I didn't have any answer 5 years ago, but now if I'm consulted by a junior resident or a psychiatrist, maybe I could advise him or her that generally it's not recommended. So this is almost the end of my presentation. So take-home message. Pharmacoepidemiology is fun, but it's maybe easier said than done. And there are a number of branching points you need to make a decision. And if you are worried when making each decision, go back to the basics of epidemiology, like what is prevalence and what do you want to compare. So comparison may be the most important. And follow previous studies or expert opinions. And don't get bogged down, or don't spend too much for small difference. Okay, and more details are in these 2 papers, including appendix and my PhD thesis dissertation, which can be uploaded on website. But if you have any questions or need my assistance, if I can, give me email anytime. So thank you very much.